Good afternoon and welcome to this week's Webinar Wednesday. My name is Terry Belcourt. I'm a nursing advisor here at the SRNA, and I'd like to thank you all for joining us today to get an update on patient safety issues and have a dialogue about those concerns. Our executive director is with us today, Carolyn Hoffman, and we'll turn it over to her in just a minute. Just so you know how you can interact with us throughout the presentation is through the chat box. Many of you have already found that and told us where you're from, so thank you so much. If you have a question, you can put it in that chat box or in the Q&A section. Either one of them we'll be monitoring and we'll bring your questions forward. Throughout the presentation, there are several polls, so we ask that you respond to those as quickly as you can. They are completely anonymous, so it's just gives us some basis and a way to focus our dialogue and promote some good interaction with you. So without further ado, I'll turn it over to Carolyn.
All right, thank you very much, Terry. Really appreciate you teaming up with me today, and a big thank you to Tony for being in the room to help make sure that the technology works. If you're having any issues, just let us know and we'll try and behind the scenes help out. So happy to see a number of people that I do know online and some that I don't, so that's particularly exciting. I'm going to start with a nod, which is something that I think is so important for all registered nurses and nurse practitioners to do, and that is my name, occupation, and duty. And so Carolyn Hoffman, registered nurse, executive director of the SRNA. And my duty today is I have the pleasure of talking to you about, I'm just going to try and advance, there we go. I have the pleasure of talking to you today about patient safety. And I've given you an overview here, and you should be able to see the slides and me if you're joining us through the Zoom video audio option. And we are going to walk through a little bit about what we know about patient safety, very, very briefly, some key trends, resources, some of the SRNA activities that are going on related to patient safety, and would love to have a great dialogue with you about where to from here on this topic. So without further ado, I will get Terry to launch the first poll, and we want your perspective. We want to start off right away by engaging you on what your perspective is. Now, don't worry too much. We do have a source of a reference for this question, and we'll tell you what that is after you share your perspective. There are no right or wrong answers, but we would like to know, from your perspective, with what you see every day, how does Canada rank on the following healthcare measures compared to other Western countries? And when you're ranking, you're thinking of where do we rank first to 11th on these three key measures of many that are measured by the Commonwealth countries and reported in. And this is a study that was done, and the perspectives that were requested for the study was from family physicians. But today we want to know, what do registered nurses and others on our line today think about how Canada ranks in terms of these key measures as compared to other Western countries? And that would be UK, Australia, the US, Switzerland, Germany, France. These are our counterparts when we talk about our measures. And so the first question is, could you go ahead and vote on your perspective about patient-centered care in Canada? Do we rank 1st to 11th on the, well, here are your options, 1st, 4th, 6th, or 8th on patient-centered care? So go ahead and vote on that, and then continue to vote on the second concept of timeliness of care. And here your options are, do we rate 1st, 4th, 6th, or 11th when it comes to timeliness of care in Canada? And finally, all related concepts, what's your thoughts about how we rate on safety and safe care? Do we rate 1st, 4th, 5th, or 10th? And these are all just perspectives that we want to get you to share today. And then I'll tell you what the study of the family physician said. So Terry, should we wait a bit longer?
I think we're probably close to, we haven't had any new ones in the last few seconds here, so we're probably okay. So I'll end the polling and share those results with you.
All right, so thank you for voting. You've said that from your perspective, and this is combined aggregate here, 75% of those voting would rate us as fourth on patient safety care, patient-centered care, rather. And one has voted us on eighth in terms of that concept. So when we look to the study of family physicians across the Commonwealth countries, they actually rated Canada as eighth. So that person that voted for the eighth, you actually are right in there with what family physicians across Canada and then around the world voted in terms of our outcomes and our effectiveness at patient-centered care. In terms of timeliness of care, let's see, we've got, oh, look at this, all four people voting put us at sixth. That is interesting. The family physician perception on that, and compared to around the world, has placed Canada at 11th for timeliness of care. So, wow, interesting difference there between what nurses and physicians are thinking. They actually place their perceptions as timeliness of care in Canada being 11th. And then the final concept there, safe care. I'll just look down. And we've got 3 out of the 4 voting participants indicating 5th on that, and 1 indicating 10th. And the 1 person voting there for the 10th, you're in line what the perceptions of family physicians were from the Commonwealth countries. So interesting to note, and really can already feel you engaging on this topic about where you think we're at, because everyone that voted actually have us rated lower than first and not placing us at the top. So you're joining with that perception already, 4 of you anyway. And I'm going to start walking through some data that does further show, with a focus on patient safety, there is room for improvement. And what can we share about that? So should I carry on?
Yeah.
Yeah. All right. So let's look at the next one. We actually know that Canada's healthcare system is faced with growing healthcare costs, increasing rates of chronic disease, and an aging population. This is almost jurisdiction by jurisdiction, something that's across Canada. Saskatchewan has some unique variations here, but in general, we have real focused issues with our costs increasing, chronic disease rates going up, and as well, a good segment, not all, but a good segment of our population aging. So when we look at these measures, I've already shared with you 3 of them, and the report from Schoen and Osborne, Commonwealth Fund 2012 Health Policy Survey of Primary Care Physicians. I left out the coordination of care there, and they asked physicians about coordination of care, and they rated us as 8th on that, really showing all these unique factors coming together for the opportunity to improve. From 2014 to 2015, there was data analyzed by the Canadian Institute for Health Information, and they get all of the records from our hospitals. And so they took all of those records in the fields that the hospitals submit, and they did an analysis, and a report was released in 2016 around harm and the harm that's happening in Canadian hospitals. And so if you're a patient safety savvy registered nurse or other person, you probably already know about the Canadian Adverse Event Study that was published in 2004. If you don't know about that, go ahead and look that one up, because that's an important study talking about harm. But the latest information, the update for us today, is around the CIHI report that was released in collaboration with the Canadian Patient Safety Institute. And this report, using 2014-2015 data, there was at least 1 harmful incident for every 18 Canadian hospital stays in Canada. And so it's really hard sometimes to put our mind around what 1 out of 18 sounds alarming. What is that? Let's put it into context. Well, for 2014-2015, that means 138,000 patients admitted to a hospital admission. 138,000 out of 2.5 million hospital stays in that year period experienced a harmful incident. harmful incident. So love to hear in the chat box or the Q&A whether you're surprised by that, whether that was information you knew about already. But let's learn a little bit more about that study just to flesh out what that harm really looked like. So the CIHI, or Canadian Institute for Health Information, and I've given you the reference here so you can look it up. I've pulled the table from their report describing the various kinds of hospital harm and how they calculated it and what the particular harms they were looking for in that data that is submitted from hospitals. And you can see there's a large first grouping there around healthcare / medication associated conditions. And these are anemia related to hemorrhage, obstetrical hemorrhage, trauma, birth trauma, delirium, and the relationship to it not being assessed as being a patient issue on admission, but during the admission developing delirium. So that would be a harm. Venous thromboembolism, blood glucose level changes with complications, pressure ulcer, electrolyte and fluid imbalance, medication incidents, and infusion, transfusion, and injection complications. So a huge section there you can see crossing a lot of different areas, all related to a harm that is potentially preventable. And what, how much is that happening? How often is that happening? And in every case, there are strategies to reduce this type of harm. Are we using them? Are we actually focused? If our issue is obstetrical trauma, are we focused using the latest evidence to reduce that? I know that we've got some medication safety experts on the call today on the webinar. We would really enjoy hearing from you, your thoughts about, the medication incidents, how high that harm rate is in hospitals, and what your take is on what's happening today. The next big section is healthcare-associated infections, and there's hardly time when we talk about harm to patients when infections doesn't get raised in the conversation. Urinary tract, post-procedural, gastroenteritis, pneumonia, aspiration pneumonia, sepsis, and our C. difficile, MRSA, and VRE. So tragic, so dramatic, so preventable in not all cases, but many cases preventable. And that's a type of harm occurring. Then we have patient accidents, and here we're talking about things like slipping and falling and having fractures, actually having an injury related to that while that person was in hospital. Hi.
Hi, I have one question for you.
Okay.
Somebody's just wondering if you'll be able to share the PowerPoint so that they don't have to frantically be taking notes.
I would be pleased to share the PowerPoint, and just so excited that you want it. Absolutely. Yep, we will send it out, and we just have to make sure we have your address, which we would, I believe. And so if we have your address, you'll get it. So great question, and happy that you're so interested in the content. And then the final section in this report of hospital harm, where they were looking for harm to calculate how often it happens, is procedure-associated conditions. And this is, again, anemia over here. So they're looking for, after someone has a procedure, did they have blood loss? Did they have hemorrhage? And correlating that back to the harm. After they had a procedure with obstetric hemorrhage and trauma, like using forceps or other things, when they had a procedure, were these complications occurring? Birth trauma, patient trauma of any kind after a procedure, well, almost any kind, as long as it's been coded and described and submitted in the chart. Device failure, something we don't often talk about, but yet is becoming more and more common in the media, is the notifications about devices failing, pacemakers failing, hip replacements. So when they're failing prematurely, known to be well ahead of their life, their projected life, that is a patient trauma because it results in additional interventions. Laceration and puncture, here a classic thing would be, say, after a liver biopsy, and there is felt to be an injury to the liver. Pneumothorax after a pacemaker insertion. which happened to a family member. I have a family member that had a pneumothorax after a pacemaker intervention. It is known to be possible, but there are great strategies for reducing the likelihood of that. Wound issues, retained foreign body, post-procedural shock, and a number of others. So I've given you this highlight here to really stimulate your thinking about that rate, 1 out of 18 hospital admissions experiencing harm, and what that looks like. So if we take that, again, it's a little hard to get our minds around it and I would love to hear your perspective about this, but we actually have to try and get our minds around it. So what does that mean? Well, if we use that data, that means 17,300 patients had at least one harmful event and then they died in hospital. Sometimes it's hard to make that direct correlation, but we definitely see increased rate of death after a harmful event happening. We can definitely see that correlation. So really important to try and get ahead of the harm. People that experience harm in hospital have an increased death rate. Estimated that patients who experience harm spend more than 500,000 additional days in hospital beds. So if we were to take that 2014, 2015 data and project that out, this means that there were 500,000 additional days in hospital beds that were not available to patients who needed to come into hospital because of a harmful event in hospital. That is equivalent, when you do the math, and CIHI did, that is equivalent to more than 1,600 beds each day being occupied by patients that have experienced a harmful event and their extended stay as a result. When you look across Canada, and this one was really powerful for me, that's approximately 4 large hospitals in Canada filled with people that are extended stays because of harmful events. So that helps us to get our minds around the magnitude a bit more, but finance information is always helpful too in terms of the magnitude. And CIHI estimated 1% of Canada's estimated total hospital spending, or $63.6 billion in 2014, related to these harms. Infections acquired in hospital are a major source, as we've said already, but let's look at that a little bit more. 1 out of every 41 hospitalizations, 2.4%, with infections being acquired or iatrogenic in hospital. It is not likely that all infections can be eliminated, and we want to make sure we're not leaving that inference here, but many can be. Many can be. A dramatic number of these infections can be prevented. And we often think about hand washing. Absolutely, but not the only thing to be done. Much more can be done, and there's some great resources I'm going to share with you towards the end on that. And I'll just ask Terry to jump in with any comments at any time that you'd like to share.
Yeah,
just give me a wave. Do you want some?
A couple of comments here about insulin errors, narcotic errors are 2 of the most pressing medication errors in Canada. And then also avoiding med errors in long-term care, where the RN primarily spends his or her time giving out medication to many patients within a short period of time. For example, morning medications, and specifically giving out those medications in the appropriate time frame. So those are a couple things that people might be interested in looking at a little bit further.
Great comments, great insight there. And yes, with the prevalence of medications and the environment, the complexity of the patients, you know, the types of high risk, which we know those are high risk. So what can we do to get ahead of that? Great comments, and love to hear if you have any strategies that you've tried out for that. So I thought I would personalize briefly this, because I always find it more enjoyable when the speaker personalizes the topic a little bit. So I'm going to do that a little bit. So I graduated in 1980 with my diploma, and there is a picture. I still have my textbook of medical surgical nursing from 1980. I know, Tony, it's going back a long ways. Yes, I was, you know, young, very young, I'll say that. And so I thought, you know what, why don't I go look in that textbook and see what did it say about patient safety? And so I've copied the reference material for you in the second picture, and you're getting the PowerPoint, so you'll be able to see my source here. But it was actually published in 1975, and so that makes sense. It would be a few years old when I would have taken it and used it for my diploma program at that point. And so out of 1975, and I've taken a picture of the index table, no, the index table. Well, it was at the back. The index, I think. Yeah. And the index, there is not one reference to patient safety in 1975. Not one reference. And this actually resonates with me because I don't remember hearing patient safety as a systems approach, patient safety as a particular concept that we had to do more work on in 1970, well, this would have been 78 to 80 that I was taking the program. And what does that mean? Well, it just means at the time, there was a very high reliance on the individual being perfect, on the individual not making mistakes. So we heard about how important it was for the individual and the accountability for the individual. And essentially, the inference was we were all, if we worked hard enough, we wouldn't make a mistake. And that was the objective, if not explicitly, implicitly. And there hadn't been the great work developed around, well, there's more to it than that. Individual accountability is like fundamental. And as the SRNA, everybody knows that we have our standards, we have our code of ethics, and the idea that we're held to those is absolutely fundamental to the safety of the healthcare system. But what happened a little bit further on in 2002 was the growing recognition, late 1990s, early 2000s, that we can build a safer system, and that accountable, knowledgeable, competent person, healthcare provider, is absolutely fundamental to safety. But when they make a mistake and you discipline them, it doesn't make the system safer. It does address their competence and their accountability and absolutely fundamental and important, but it actually doesn't make it so that the registered nurse beside them on the unit won't make the same mistake because of system issues that may be in place. And so I'm very happy to tell you that I was able to work with the National Steering Committee on Patient Safety and write Building a Safer System, the National Integrated Strategy for Improving Patient Safety in Canadian Healthcare. And to get ready for the webinar today, I actually took time to go back through that report. And if you haven't read it, I would encourage you to go back. It has many strategies that were recommended for improving the safety of the system. And a number of them have been implemented, but a number of them have not. And so 2002, this idea that the system had accountability and the system needed change and improvement began to be more prominent. And so I love two quotes from the report, the Building a Safer System for Canada. And the first quote is from Dr. Berwick out of the Institute for Healthcare Improvement. And he said, "We envision a system of care in which those who give care can boast about their work, and those who receive care can feel total trust and confidence in the care they are receiving." And, you know, back in 2002, we thought, like, in a few years, that's exactly what's going to happen. We felt that this was a wonderful emerging concept idea. The system would make these changes, and this is what we could talk about. Clearly, there are many that can boast about their work. Clearly, there are many that say they feel trust and confidence in the care they're receiving. But if we're having the infection rates that we're having, and if we're having the other types of harms that are occurring, like the decubitus ulcers, the medication errors, etc., can everyone feel 100% confident and total trust in the system? Not yet, not yet. But that's why we're talking today, because never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. I haven't seen the quote used lately from Margaret Mead, but it's used a lot, and some people tend to almost think, oh yes, of course. No, the the only way patient safety is going to be changed effectively in every area is if small groups of thoughtful, committed citizens, registered nurses included, and many others, and NPs and many others, coming together and locally saying, we can do this, and making that change. And there's no top-down to this. It's all bottom-up. But there are some top-down strategies that can enable it. And we'll talk briefly about those. Here's a couple of diagrams from the 2002 report, just to make sure we're all positioned on this discussion for going forward. And James Reason, Dr. James Reason, is a fantastic, well-renowned expert. And everyone talks about his Swiss cheese model. And if you haven't heard about Swiss cheese model, in fact, he never called it that. Somebody else did, but the name stuck. And the Swiss cheese model is a great way for us all to think about what comes together on any given day, at any given moment, for harm to the patient. Because each slice of the Swiss cheese has holes, and those holes are dynamically breathing every day. They're getting bigger or smaller, bigger or smaller. One of these slices is the registered nurse at the point of care giving medications. And I love, and we're going to go to the chat shortly to hear some of those thoughts about medication safety. So why don't we use this example? Each of these slices really is very dynamic, and one would be the registered nurse that's going to give, in a long-term care setting, the medications. Is that registered nurse new to the facility? Is he or she new to the drug that they're giving? Have they given it before? Have they seen the patient having some complications, but they're not sure? Do they have enough time to do the assessment and do the analysis and any changes that are needed? Some of the other slices might be the medication delivery system. Is it unit dose? Is there a barcoding process where the provider can scan the drug and scan the armband and know for sure that that's the right drug for that patient? We're not there in a lot of cases, but that's what technology could do. Is there technology helping this person to do the right thing? Another slice could be the actual family or patient themselves. What do they know? I know, like lots of you, we have aging parents. My mom, I weekly go through her medications and talk about each of them, right? When she gets into the hospital at some point, if she does, she's going to have some base knowledge. She's going to be another slice. And if someone has worked with her to have that knowledge of her doses, she's going to be able to say, wait a minute, that doesn't look right. But then the RN or whoever's providing it needs to say, oh, I'll go check. We'll talk this through. So lots of different slices there. So should we go to the chat to get that?
So I think in response to, what are some of the strategies for mitigating some of the issues with medications, one said we're teaching independent double checks, not just double checks. There's a difference that we need to remind people about. So that independent double check process. And then also in the Saskatoon Health Region, we're using insulin basal bolus nomograms that dramatically improve patient safety based on evidence-based research. We're also regulating, I think, glucose levels and reducing A1Cs, a win-win for patients.
What a fantastic example. Anything else to share?
No.
Not yet. Continue sharing. We want to see what you're doing. I'll just reinforce that very often we think we're doing an effective double check when we take our calculations or we take the order and we have already decided what we're going to do, and we just go to another registered nurse, in this case perhaps, and say, here, this is what I've figured out. Does this look right to you? That is not an independent double check. That's a double check. And that's exactly what we're hearing out of Saskatoon is that, yep, people have often thought that way of double checking is great. It's not the best way. Independent double checking is truly having another person from scratch, from the beginning, look at everything, calculate themselves, and then compare what the actual outcome is going to be. And true independent double checks would save lives. And we're still not there entirely. And there's still issues. How much time is there to go ask another colleague to do an independent double check? Do we have that built in? Very often it's hard to find another colleague. So then we've taken away a very good process and not always had the opportunity to do it correctly in a case like that. And the nomograms, great. You're really using evidence. You're bringing that to the unit and making it easy for the registered nurse or NP to do the right thing. So well done. I love a win-win. That's great. Okay, we'll move a little bit further in the 2002 document, Building a Safer System. Again, might be a little bit hard to see, but you can look at the original anytime. And I love this one because here I am, Executive Director of a regulatory body. What's my role in the system? Well, we're on here. We have an illustration of what the system looks like. We've got that sharp or pointy end where there is a provider with a patient, client, resident, and there's a team around them. There are environmental factors, there's task factors, do they have a nomogram or not, etc. And that's the sharp end, and I love that name. I still use it, sharp end, because that's stressful. When you're at the point and you have to make sure that you're the last step in this, your system isn't behind you, that's painful, not only for the patient family, but for the provider. And the concept of second victim and how hard it is when we make mistakes, that's where it resides there and how much we have to support it. So when you look at the blunt end, you're looking back at the management decisions for that setting, for that provider, the organizational regulatory factors. And here's where SRNA is, here's where the government is, here's where the board of the Saskatchewan Health Authority is, the senior leaders, the leaders. We're sitting there and we're needing to do our work to make it easy for that sharp end interaction to be done safely. And so I love the idea of this illustrating. So when we look at why an adverse event happened, we're looking for the root causes well back in the regulatory organizational management part of the system. That's where the root causes lay. And some people like the term root cause, some don't, but the point is the contributing factors to an adverse event or harm are not just at the point end, more importantly, they're at the blunt end. And if we don't set up our analysis and actions, we're never going to make a difference. So that's the way I love the diagram. Would love to hear what you think about that diagram too. So let's fast forward to today. And boy, there's been a lot published about patient safety since late 1990s, early 2000. I was going to Google and see how many references came up, but we'd have hundreds of millions. And isn't that exciting? Yes. Where are we on the journey? Not there yet. So I'm very happy, and I'm going to hold this up because I get to put a great recognition out here for David Gregory, Dean of Nursing at the University of Regina and Dean of many nursing programs, including the SCB-SCN program. So a shout out, I don't think he's on, but a shout out to him, David Gregory. He's lead author for Fundamentals, Perspectives on the Art and Science of Canadian Nursing. And I put a picture in the PowerPoint for you. I have it beside me. So this is actually a textbook out of 2015. Heck of a long time later. Really good read for anybody that is interested. It's published in 2015. What do we see here? 20 pages on patient safety. We see 30 different concepts being talked about related to patient safety. So we see the educational system moving forward. But me, I graduated a long time ago. I don't get these textbooks usually, right? And at the SRNA I do. But if I'm in clinical care, point of care, I don't necessarily have the time or access to the emerging evidence on this. It's exploded. It's great that it's in the curriculum. Where to from here? So I wanted to highlight a few of the key trends that are occurring now around patient safety, and I'm only going to highlight some. And oh, Liz just has a comment for us. If you
that, yeah. So there's a new updated edition of the Gregory text in progress now. So that's exciting.
Thank you for the update, and please pass along to Dean Gregory that I did a shout out about him on the webinar.
There was one other question just about the independent double check conversation. So what about long-term care facilities that employ only one nurse per shift and there's no other nurses in the building, only CCAs?
Yeah, you know what? I would love to sit down with that issue about what can be done. We're going to have to rely on technology. We might have to rely on some pharmacy support here, or pharmacy information. And what you want to do is be connecting somehow in certain circumstances, and it wouldn't be for every drug, right? We have to look at what are the high risk, what are the things in the moment that might change, and you need access to someone on this, and we have to make sure that that registered nurse does have that backup. And so when you're talking about a high-risk drug in long-term care, what can be set up with other nurses, LPNs or RNs, with pharmacists to have some pre-done work that actually helps that nurse that's administering it to have independently confirmed it. And then when something is unusual or different, what is that backup for that registered nurse? You know, we talked about new registered nurses coming out. Very important that they have access to be able to ask questions and address them. So some of the key trends, and as I mentioned before, and I'll just remind everyone on, can you please share your key trends, because you're engaged, active people, so what are you seeing out there? But from my perspective, I've had to pick three, so I picked three key trends, and the three that I'm going to talk about: patient and family engagement. And this is a real buzzword right now. I don't think we go very far every day without seeing or hearing about patient and family engagement. It's exciting that it's being talked about more, but what are the implications and what actually is the goal? So there's a number of different ways that can occur. So I want to give you a few examples so I can flesh out what I mean by patient and family engagement. First and foremost is full engagement in care priorities and decisions. And our system doesn't yet enable this. So we're not there yet, but in research and in organizations where the concept is implemented, are finding care safer, more effective, more efficient. Full engagement. What are the priorities? Not here are your priorities from the registered nurse perspective or the physician perspective, NP perspective. What's the patient and family priorities? And working back from that. And the decisions need to be the patient and family decisions informed by provider, of course, in collaboration with provider. So we're still learning about this concept. We actually don't know how to do it in a widespread way yet. And I try and stay on top of the literature and in discussions with colleagues. And we're not quite there in figuring this art and science out for that. So any thoughts you have about that are greatly appreciated. Incident analysis, I'm actually going to talk to you a little bit more about incident analysis because I did some extensive work about 10 years ago, up to about 5 years ago, on incident analysis. And I'm not sure how much effort and energy and capacity is in our system today. And so just some thoughts to stimulate discussion. It's a relatively new concept. I talked to many organizations directly or indirectly in Canada. Very few, but some, have patients and family advisors sitting in on the group that's looking at a particular adverse event or critical incident. What do you think about that? How do you feel? If you had been on a unit and there had been a major medication error, major error of some kind, lots of system issues, patient maybe died, patient may be severely harmed, patient may be recovered, maybe not. Patient and family advisor that's been educated and empowered is on the team to look at what happened. Some organizations are finding this the best actual strategy to engage staff, engage physicians, and focus everyone's attention to what is the role, what are the things from the patient and family perspective that could mediate harm, prevent harm, mediate it. And this actually is making dramatic inroads in many places. It's walking the talk. If I tell you that we're going to give you safe care and something bad happens, you better be involved with us, because shutting you out feels awful. So engaging. Program redesign. Program redesign is, wow, we experience this every day around us. Program redesign. There's big change in hemodialysis now. We're going to redesign it. A big change in day of surgery approach. We're going to redesign it. Again, organizations that walk the talk, registered nurses that walk the talk, engage the patient and family in an educated, informed, empowering way to design that new program or adapt that program. And again, when that does happen, the outcomes are better, generally, as long as it's effective. And then there's advisory committees, and I had the pleasure of working with the, well, she's the CEO now, Dr. Verna Yu, but at the time she was the Vice President for the Chief Medical Officer, Vice President of Medical Affairs in Alberta Health Services. And we had a province-wide patient and family advisory committee. Dr. Yu and myself, best part of our job. What are those patients and families that are engaged and empowered to speak up and partner with us? What are they saying now, and how do we go on the journey with them? So very important. Investing in effective teamwork. This is a second key trend. I was part of some work in Alberta, seeing some work nationally. It's an art and science as well. So nursing is an art and science, medicine is, pharmacy, PT, OT. So if we believe that effective teamwork will automatically happen, we're naive. We're sleeping, because that's not going to automatically happen. And there's been some great leaders like Dr. Alan Frankel, who has done great studies around what do you do to create the environment for open and effective teamwork. And it's lovely common sense in many ways, and also very, very new in some of the strategies about creating safety for the team to truly share. And us showing up and saying, you can share whatever you want, doesn't work. I wish it did, really wish it did, but it doesn't. So what do we need to do? Well, now there's a whole initiative designed to lay in the education and infrastructure to help teams work together, identify issues, work with patients and families to improve and reduce harm. And finally, focus strategies for improving patient safety locally, and so incorporating the first two trends, now wrapping into it, using the data to see what the major harms are that are happening in a particular area, and what can we do to reduce that. So I'll just pause there. Do we have any new?
No new topics, no new questions.
All right. Would love to hear what you're thinking. Are these resonating? Am I way out there? Well, I know I'm way out there, but do they make sense? So in terms of some key resources, I'll briefly highlight, and then I would love to, we're able to open the lines maybe for some discussion, or all through chat?
Through chat.
Okay, so I'm going to prime you now to be ready and maybe typing some thoughts, because we're going to end in just a few slides and have a dialogue about where to from here. Well, I do see a question. Do you want to bring that one?
So is there still a provincial requirement for healthcare facilities to report critical incidents to the Provincial Ministry of Health?
Great question. Yes, there is still a requirement that is still in place. And I do, from time to time, the SRNA receives a, what do they call them? Critical Incident Patient Safety Alert?
Yeah.
Or very similar title, where I would say probably once every 3 or 4 months, something like that, we do get a alert that says, here's something that's happened, and here's what should be done to reduce that risk for other patients. And so with and another great question, I'll just roll with it, is aggregate data available. You can go on to, you have to look for it. I love these questions because I've been looking for data too, so this is great to see we're on the same track. You actually have to look quite deep to find the Ministry of Health critical incident reports, but they are online. They are within, at the back of their annual update. So if you're looking at for this data, one option is to go online and look at the annual updates from the ministry, and they're right at the back. They're actually, I don't know if that's, anyway, we won't, but they're at the back. And the other way is to directly ask the ministry, because I always think it's great for them to know if someone is interested in this information. And there are very knowledgeable people at the Ministry of Health that are excited about patient safety. I know that because I used to work there, and they've reached out to me in terms of future planning and moving forward in the new Sask Health Authority in terms of this. So there are people that want to share it, I'm sure, could look at how to share it. So great questions. So very briefly, and I'm going to go through them very briefly, if anyone wants any more information on the resources, follow up with me offline and chat and let us know that you're interested, but I'm more than willing to spend time in detail on these resources. The first one is the Canadian Incident Analysis Framework, and I was lucky enough to be one of the co-authors of this framework. It is developed in collaboration with CPSI, the Institute for Safe Medication Practices Canada, Saskatchewan Health, and Patients for Patient Safety Canada. And it is a lovely framework that talks about what organizations and registered nurses, individually and collectively, can think about when thinking about adverse events. So let's start on the right-hand side. Before an incident happens, what is your leadership saying about incidents? Are they open to hearing about them? Is this a culture that we can talk here, or is it pushed back? It's important to know the policies, to know what the organization expects, but we all have our code of ethics, and I brought mine. We know what it says about us having to, if we know something is going to harm a patient, we have a duty to bring it forward and be talking to our managers, be talking to our leaders about it, and engaging patients and families to reduce that risk. So then there's an immediate response if a critical incident happens, and the sub aspects are there. There's an analysis, but if you don't prepare properly for it, you're not going to get a very good outcome. So what can you do to methodically get ready so that when you do bring the team together, you do analyze it, you're coming up with the actual root causes. So no matter what you call it, root cause, contributing factor, very often these analyses can end up very superficial. Well, we need more nurses. Well, we can talk about that. Sometimes that actually is what's needed. Sometimes the appropriate technological support, the appropriate backup is needed in a different way. And so we need to think and get to the right root causes, or correct as far as we can determine. The follow through, well, if everyone comes together and makes recommendations and no one makes sure that they're implemented or see whether they helped, that's not going to work either. And then closing the loop, sharing in the organization builds that culture. So if I know we can talk about it, so if I get an alert that says we had this bad thing happen and this is how we're going to get better, I know that I can bring that forward. So you're actually building a system that you want if you're going through these phases. As recently as a few months ago, this adverse event Canadian Incident Analysis Framework was being used by a very large organization in Canada to move forward their work on patient safety. So I know it's still timely, at least in some areas. Should we bring forward? Or
sure, there is one strategy that's been shared for harm reduction in patients with addiction and substance issues, and that's a safe injection facility in Saskatoon. This is demonstrating adherence and safe management of the entire length of care for infections such as endocarditis, safe spaces, adherence to care, reduces healthcare costs, and effective management of the patient, illness, or infection.
Well, thank you so much. It just, it almost catches your breath when you think about the opioid crisis, the harm, potential for harm that's has been and now escalating in many ways. And to hear about a team that's obviously getting together and working on this and reducing risk to patients and families is very exciting. Thank you. Keep sharing. And a few more resources. ISMP Canada I mentioned briefly, just related to the Canadian Incident Analysis Framework. They're a great resource on medications. If you don't know them, I encourage you to go to the site. And I put a slide in here. If you had a medication error happen and you think, yes, I'm going to report it into my local system, but I want people in Canada to know about it, you can anonymously report. It is a great way to make sure that it's going to somewhere where it can be aggregated for safety across the country. The CIHI, or Canadian Institute for Health Information report that I talked about earlier, guess what? There's a webinar coming up, and there actually is a faculty of individuals from across Canada, including the CEO for the Canadian Patient Safety Institute, a member of the Patients for Patient Safety Canada, Josh Tepper, a president and CEO from the Health Quality Council in Ontario, David O'Toole from the CIHI, and Tracy Johnson from CIHI, coming together January 25th. So I'll just leave you with that teaser. They're going to be talking about harm and all of the resources that have been compiled to reduce that. And so if you want one of those short-term actions that you commit to and you want to do in follow-up, there's an idea. Some of the others are engaging patients in patient safety, a Canadian guide for patient engagement. So I didn't want to suggest it as a trend and not leave you with a tool. So there's an amazing tool by CPSI. Some of the information from my presentation today is in there and much more. The Canadian Safety Competencies, CPSI, or the Canadian Patient Safety Institute, has a number of years ago, I think in 2009, released the safety competencies. This is very exciting because this is distilling down to more concrete details about what is the competence we need. And certainly we look across 6 domains in the safety competencies about a culture of patient safety and what are the competencies you need for that. Working in teams, communicating effectively, managing risks, optimizing human and environmental factors, recognizing, responding, and disclosing adverse events. The patient safety competency is a great resource for those of you teaching, but a great resource for all registered nurses to look at and say, where am I in those competencies? Still a little bit too high level, but a great start to the dialogue of reality and bringing it down. So with that, I've got one slide left around some new content around our SRNA activities. Patient and family engagement. We're walking the talk. We did hold a patient and family advisor in 2016, and we had 2 of the advisors come to our council in 2017, and the result is that the SRNA will be launching a patient and family advisory committee this year. That committee will be advisory to council directly. I'm excited. That means we're getting that voice. That means in all of our standards and competencies and in our work, we're bringing that voice to bear. The safety competencies, I'm on a working group with the Canadian Patient Safety Institute and CASN, the Canadian Association of Schools of Nursing. I'm on that. It's an advisory committee on patient safety in nursing. It's so exciting because we're taking those higher level competencies and we're translating them down to nursing and to the undergraduate program. And we're doing a resource. We're not able to dictate, for sure, as a group, as an advisory committee, but we're developing a resource so that schools of nursing through CASN will have a structured kind of tool to help them translate those competencies to their programs. And finally, the SRNA is developing new RN entry-level competencies in collaboration with our regulatory nursing colleagues across Canada. We expect those to be out in draft this year, and we want to engage you. So stay tuned to my ED updates, our website, for more information on that. And we're also updating our program approval RN program manual. So lots of work, and patient safety is coming in many places. These are only examples, not comprehensive list. And where to from here? So I see we have some more thoughts, Terry.
Yeah, there's so an example of labeling is the incident of mislabeling heparin and insulin in the pharmacy. That can be a concern. With poor conditions in the preparation pharmacy site that led to a severe incident in administration of TPN in the NICU unit. We've learned and are implementing many safety practices in all stages of medication preparation and delivery from this very sad and severe incident. And just looking at what other information related to patient safety that might be helpful is looking at more interprofessional collaboration and committees.
Well, thank you for sharing. There are tragic adverse events, tragic harm happening. So hopefully that's one thing that we've been able to be, and great sharing on that reality. How best to prevent that from happening again, to recognize, disclose, honor the harm that's happened, and take that and learn from it. And so good to see that you actually feel you're doing that and that you're able to bring and learn from that. So thank you for sharing that. The interprofessional collaboration, wow, we didn't set this up, whoever shared that. We never set this up, but look at my picture on the last slide. It's a whole team. It's a whole team, and it truly does take everyone involved, right, from whatever direction you want to come at this, to actually meaningfully change patient safety. One of the big things about infection control is the cleaning that goes on, and then the approaches that maintain not contaminating, whatever the environment is. Well, that's literally everyone from every direction involved in that as one example. So I agree, interprofessional collaboration. And so a great takeaway for the undergraduate program is making sure there's lots of that, so that's just the way they work. And for those of you working in point of care, policy, research, and other domains, you're going to be able to influence that as well and design to actually do that. So one last opportunity in the last minute for any further comments, and then really invite you to reach out. Terry and I would definitely be more than pleased. I'm actually pleased to tell you that I'm working with a representative from a organization in Saskatchewan around incident analysis. They want to do some further work on it, and so I do believe that's important. And so if you want more information on anything, we will include that in the PowerPoint, our contact information.
Yeah.
Yeah, I forgot to put it in the last slide.
Yeah.
So we'll put it in the email.
The other thing that you'll receive is a link to a survey to provide some feedback on this presentation. That's part of our, just making these presentations the best that we can. You will have noticed that this is part of our emerging trends in healthcare series, which is sort of a new way to organize our webinars this year. So we're excited about that. Next week, we're focusing on professional accountabilities, and completing continuing competence program forms is our topic next week. So hopefully we'll see you back here then.
Thank you.
Yeah, there is a comment just that awareness is key, and lots of thanks for the information. So very good.
Great. Thank you for joining, everyone, and I look forward to talking to you again, and I know Terry does too.
Yes, just a couple quick little reminders. Nominations for SRNA Council is due on February the 2nd. So if anybody is interested, please send us a note. We can send out the information to you. It is on our website as well. But we are looking for council members actually in Saskatoon and to Regina. So we'd be happy to talk with you more if you're interested. And we're also looking to recognize outstanding registered nurses at our awards program and at our awards banquet in May. So again, the deadline for nominations for awards is February the 2nd. So hopefully we will hear from you. This webinar has been recorded, and we will post it to the website. So if you want to share it, send the link to friends and colleagues. That'll be available in the next few days here. So thank you all for joining us and have a wonderful day.
Thank you, Terry.